Welcome to our Quality and Diversity in Radiology Q&A. I am Lucy Maguire, a fourth-year medical student and president of the Glasgow University Radiology Society and the SRT Medical Student Rep.
I'm Akib Mahmood. I am the final-year medical student at University of Sheffield, and I'm also the treasurer of Sheffield BAME Medics Society and treasurer of University of Sheffield Radiology Society as well.
Today we are talking to Dr. Cindy Chu, a consultant radiologist and honorary clinical associate professor at the University of Glasgow and the British Society of Gastrointestinal and Abdominal Radiology Standards Officer.
And Professor Amaka Offiah, chair in paediatric musculoskeletal imaging and consultant paediatric radiologist, and also the chair of BAME Staff Network at the University of Sheffield.
So welcome everybody. Our first question is, can you tell us a bit about your background?
So I'm Cindy. I'm Cindy Chu. I'm originally from Singapore, from a very working class background. Neither of my parents were university graduates. And I got a place in Glasgow University to study medicine here. So I came when I was 19 and I've stayed in Glasgow ever since. So yeah, that's me.
I'm Amaka Offiah. Academic radiologist, and most of today's conversation is going to, from my point of view, we'll look at academics. I was born in Scotland, Edinburgh. My father came from Nigeria. He was a medical student there, and he qualified, and he had the first 3 children there. Then I went back to Nigeria, so I actually qualified from medicine in Nigeria. So I'm in fact what you call an overseas student in a way. And then I came back to specialize in radiology, clinical radiology. Then I ended up being an academic. It was never a planned thing, but here I am.
Brilliant, thanks so much. And our follow-up question to that is, how has being a woman of minority ethnic background affected your journey into radiology?
So I'm going to kick off, I think. So when I was a medical student, I would go back to Singapore for my long summer holidays because it's cheaper to go home, obviously, than to stay here for 3 months doing nothing. So I went home, and my parents, being Asian, said, no, you can't just sit around in the house doing nothing. So I was farmed off to be a research assistant to one of the surgeons in the National University Hospital. So I spent my summers being their research assistant, which back in the day meant looking at lots of case notes to kind of fill out their pro formas. And occasionally I get invited to surgery. They say, come along. And they were one of the kind of early adopters of keyhole surgery or laparoscopic surgery. And the guy I was with was really into all the kind of new technology. And he, in fact, went into needlescopic surgery. So not only was it 5mm ports, he was using 1 or 2mm ports. So, we would stand and watch. And I remember at the end of second year medicine, I thought I would never do, whatever I do in medicine is not going to be surgery because it's utterly boring standing there over 100 hours. But after graduation, actually, we ended up thinking surgery is the thing for me because I thought, if people were in pretty dire straits by the time to come to the surgeon, the odds of doing something to help these people were quite high. So the risk-benefit ratio worked. And there's a long-winded way to say that I spent about 4 or 5 years in surgery, and I really, really wanted to do surgery. And multiple things kind of happened. And I think the fact that I was, at that intersection of being a woman, an ethnic minority, somebody not British, probably contributed to some of the things that happened. And in fact, I decided actually the best thing for me was radiology, because radiology is where all the exciting things was happening, the diagnoses was happening there. And once you have the diagnosis, anybody can treat the patient. So we went into radiology and never really looked back because I think radiology was really fantastic. My radiology training was wonderful. So I think it has affected me that way.
Yeah, I think for me, if anything, I would say it was positive. I was in boarding school here. I was born here and I stayed here till I was 12, I think. And some of those years were in boarding school, and there was certainly bullying, more so in the boarding school. Well, maybe maybe not as bad as for my cousins who were in London, but I was certainly bullied. Then you go to Nigeria, and everybody is a black, or a few Asians, and one or 2 whites, but predominantly you are the ethnic majority. So you know maybe that was good for my confidence. We had a visiting professor and another visiting lecturer who came armed with their radiographs and some CTs, back in the day CTs, you know, single slice, really, really very poor quality, but they were amazing as far as we were concerned. And as far as I was concerned, I was going to do radiology. So I came back to this country after I graduated, having forgotten, it's like labor, isn't it? Having completely forgotten all the pains of being bullied and whatever, and not even really necessarily knowing that I was black or female. I mean, you know these things, but you just go through life without thinking about them. And then I applied. I must have sent in 50, 60, 70 applications, having passed PLAB my first go. So I was very focused, you know, on doing radiology. And I made all these applications to all of it, and I just didn't get any jobs, you know. And I'd passed the PLAB in the February, and the way house jobs, we call them house jobs in those days, was that you would have to start on the 1st of August, I think it was.
Yes.
And so my time was running out. And some Asian radiologist, and I wish I had remembered his name. At the time, I was maybe just too looking into myself and my life and my difficulties, actually responded. Nobody else ever used to respond to the CVs, you know, and the job applications. You just wouldn't hear back, and you know you hadn't been shortlisted. So I was never even shortlisted. I'm not talking about coming to interview and not getting, not shortlisted. This person wrote back a letter, and he was Asian, from his name and male, and he said, you won't get into radiology this way, having come from Nigeria, and you know, even if you've got PLAB and everything, I would advise you to do MRCP first. And I took his advice, and I did my MRCP. I did house jobs in general medicine, got MRCP, and got into radiology. You know, thank you to him. I've never been able, I didn't save his name. I've never been able to go back and thank him, but he was an Asian who saw that, and he had no idea of knowing that there were 59 other applications I'd sent in or whatever. He just was able to say, this is not going to work in this climate at this time. Thank you, wherever he is. So I think it worked positively in a way.
Our next question is, what do you think of the current levels of diversity in radiology, and how can we further diversify?
I'm going to talk about it from the point of view of academic radiology. And we were talking earlier when I apologized for not having slides, and I hope it's not going to be death by numbers. I've written them down because they're not all in my head. So the survey of medical clinical academic staffing levels that was last conducted in 2017, and radiology as a specialty had one of the lowest absolute numbers of academics to start off with. But of those academics, and I think there were 60 in total, 30% are female. So I'm in the minority already. And then if you look at the professors, 20% of professors were female, and all those 20% work full-time in comparison to the 80% who are male, and 20% of those males work part-time or less than full-time. So there are fewer women, and the women who are there are working full-time, which sort of suggests to you that they feel they have to in order to sort of get there and stay there and be respected for being there. And then of the 60 academics, 4 were of unknown ethnicity, which leaves 56. Of those 56, 12 were BAME, and none of them were Black. Actually, I was working in 2017, so there should at least have been 1 Black. So, but even then, if there was 1 Black, the others were Asian. So that tells us that in academic radiology, we have a smaller percentage of academics than we should have. We have a far smaller percentage of females than we should have, and an embarrassingly low percentage of BAME academics. And in subsequent questions, this has a bearing on some of your subsequent questions. So very, very much more work to be done. Is that English? Much more work to be done. Very, very poor statistics and much more work to be done. Over to Cindy.
Yeah, absolutely. I completely echo Amaka's words there. I've got some slides. Hopefully, it's not death by PowerPoint. So like Lucy said, I am the standards officer of the British Society of GI and Abdominal Radiology. And that's our website and our logo. And I'm also the standards officer. So that's a new, also their diversity champion. So that's a new role. And we basically kind of felt we had to respond last summer after the murder of George Floyd. So, you know, what can we do? We are a small society. We only have 400 members. We have not much resource. What can we do? Our president decided that we needed to do something. So we very quickly drafted a diversity statement and an action plan. And that is very prominently displayed on our website. We decided to task the diversity champion with the responsibility to diversify and to be inclusive and to make sure that as BISGAR was practicing inclusive membership. So what BISGAR did, we drew up a diversity statement and an action plan, and the standards officer was tasked to be the diversity champion. We audited the membership list to find out who was making up our membership. But we understand that there's obviously limitations looking at people's names, so we also supplemented that with the anonymous membership survey. We also audited the annual meeting that BISGAR runs to find out who we were inviting to chair and who we were inviting to speak at these meetings. We were also auditing the executive committees. Now, the executive committees is not appointed. It is something that, when the post becomes vacant, people nominate themselves and it goes through voting. So it's a competitive process. But still, nonetheless, we wanted to see who was making our exec committees. And based on all this data, we then decided to set some standards as to what our meetings should look like and about our executive membership as well. So the first thing to kind of say really is that the vast majority of the people who responded to the survey, which is over a third, we had almost 90 people responding, was that they strongly agreed that BISGAR is an inclusive and equal society. So that was kind of the baseline. We felt good about that. And then we looked at what the membership looked like. So we looked initially at women. So we know that women make up just over half of the population. And obviously, Amaka is giving the academic point of view. I'm giving you mainly the kind of clinical point of view, the kind of a practicing radiologist, kind of on the ground. So the RCR, according to their data, 38% of the RCR fellowship membership are women. And then in the context of that, 37% of senior doctors in the NHS are made up of women, but then increasing numbers of women are making up the workforce of the NHS, junior doctors. And in fact, if you look at the RCR's own data, when you look at the registrar level, it's actually more than half of registrars are women. So there is a kind of a groundswell, hopefully. The future is looking good, but there are a lot of women in training in radiology. And compared to that, the BISGAR committee is not to that. We're pretty healthy. We've got the committee at the moment, 40% of us are women. And in the membership survey, 46% of the respondents were women. But the interesting thing was when I was actually doing the kind of name looking, about a third of membership were women. So what we could see from that is women were more responsive to calls for surveys. So they were overrepresented from that point. And then we looked at, the ethnic minorities, people who are not white in this context. So we know that the NHS is almost 50% made up of people who are not white. And the RCR numbers are 18%. 20% of the RCR numbers, we don't know what their ethnicity is, but of the ones that we do know, 18% is ethnic minority. And BISGAR committee is a third, almost 30%, and BISGAR survey is 34%. And what's very interesting is when I looked at the names only, and I looked at the junior members, so junior members are people who are not consultants, registrars, 56% of BISGAR junior members were had an ethnic minority name. So a lot of registrars are joining BISGAR, and I thought that was an important thing to kind of highlight to the executive committee when I was presenting my data. And this is against the backdrop of the UK overall population of 13%. of people being of ethnic minority, and in Scotland is less than 5%. So, you know, these kind of stats is, I think, quite useful, and it's probably food for thought, because, you know, there are people who say that we need to, absolutely, the doctors need to reflect the population of patients we're dealing with. And it's not just, obviously, when we talk about diversity, it's not just gender, it's not just race or ethnicity, it's also disability, it's also about sexuality, age, and all that kind of stuff. But these are just the two things that I managed to look at. So, you know, it's a very interesting thing from that point of view. And then I looked at the people whom we were inviting to be chairs and people who were inviting to be speakers. And in the last 20 odd years, the historic representation of women and people of ethnic minorities as both chairs and speakers is very, very low. But the last couple of years has been much, much better, as you can see, a much more healthy mix of numbers there, although still a fairly low number of ethnic minority speakers asked to speak at our meetings. So as a result of all that data, we kind of made commitment of how to actively or proactively make sure that our society and our executive committee and our meetings are inclusive and diverse. So the first thing we decided was that from the committee's point of view, that 30% should be women, at least minimum, of the committee. And not only should they be women, 1 in 3 of the key committee roles, that is president, secretary, or treasurer, should be a woman. We also would like to aim towards 30% of the executive committee being of ethnic minority. So these are the kind of standards we thought we would try and meet as far as the executive committee is concerned. But as far as the meeting chairs and speakers are concerned, we set the standard at gender parity of session chairs, because there's no reason why there should be more men than women being chairs. So that is something that we thought we should set. And we thought we should have a third of the chairs be at least ethnic minority members, ethnic minority people. So that is, you know, we're also including them in the demographics. And we also should have a third of speakers being women or ethnic minority origin. So that is the way that we thought we could embed that into our society. And that is something that the standards officer or the diversity champion has to report on every year. And I'm very pleased to report that the targets have been met. So we've already planned BizGar 2022 and we've met all that. So that's really good. And in addition to that, we've also started a mentoring program. Now, all junior members are eligible to apply, whether you're black, white, or polka dot, as this is a movie that I really like speak about. But we were strongly encouraging of women and people from members from the underrepresented, you know, minorities to apply. And I'm very pleased again to report that all the people who applied fell into that category. They were either all women, and the 2 men who enrolled in the program were people from ethnic minority origin. And they all got their first choice mentors, and we've just had our training, and so the mentorship was up and running. So that's really good. And also I put on my details out there in the committee, in the AGM, so that people in our membership can contact me to let me know how much more we can improve. And if we're doing badly, tell us why, you know, what we can do to be better. And if we're doing good, let us know too. So it's kind of being open with the membership and asking them to kind of feedback to us and keeping that dialogue open. And if you're interested, this QR code will take you to a paper of what we've actually done. So that is BizGar, and I'm very involved with that. And the Royal College of Radiologists also has a page which talks about diversity and inclusion. And even though they don't at the moment have their own initiative, they have at least thrown their weight to some of the initiatives that its members have you know, stood up and started doing. And the first one I like to really highlight is the RadReach program. And this is a program aimed at reaching people who are, you know, ethnic minorities, you know, FY1s, FY2s, to encourage them to join radiology and oncology. And this program is set up by Dr. Noel Barrow, who's a post-CCT clinical fellow in St. Mark's radiologist, and also together with Jade Scott Blagrove, and as well as Hannah Thamalingam, who is one of the vice presidents and who's an oncologist of the College of Radiologists. And Dr. Obaro wanted me to give a shout out to her Twitter. So if anybody who's interested, any of the medical students out there, please follow them and they can get more information on this. Another of the program that RCR is throwing their weight behind is the Hexaret, what they call the Mobility Scholarship. And I am pleased to say that I've been co-opted into this program. And what they do is they've offered a scholarship to, and you can see the criteria that, of what they're following, the criteria of people they're trying to encourage to apply for this scholarship. And the idea is first generation medics from ethnic minority. And this is in response to St. George's open letter that the students wrote to the medical school saying, that there needs to be greater inclusion and diversity of them. So in response to that, Hexaret set up the scholarship, and we've already awarded the first winner this year, first scholar. And the idea is they get a one-to-one leadership training, and mentorship over the course of the year, and they will be given a research project to do. And if that project is submitted and accepted into various conferences, they'll be given funding to attend that. So these are a few things that's happening in the radiology community, and I think that we are all trying to improve diversity in radiology.
Brilliant. Thank you both so much for your responses. And just to follow up on that, are you aware of any disparities or barriers to achieving a good radiology practice for patients in minority groups?
Well, I mean, there's lots of papers. There are lots of papers out there, particularly in America, showing disparities, not just necessarily with ethnicity, but linked to socioeconomic status, which are very sad reading, actually. The extent of the health disparities, not very many studies, as I am aware, specific to imaging, but health as a whole. For talking about research, as an example, we know that there's much less access, much less inclusion of ethnic minorities into research projects, and there are so many different reasons why that might be. One of them being language. So there are language barriers, and researchers may have to have their information sheets and consent forms translated, and then translated back into English to make sure that the meaning is not lost. That's an excess cost, which they may not have. Then there's the issue of trust between the researchers and the patients, and even healthy volunteers who are being recruited into these projects. And a lot of projects the cultural is that it's better to have the researcher speaking to you be a woman, in that a man can be spoken to by a woman on his own, but a man may not want his ethnic minority wife to be spoken to by a man on her own. And I've shown you the statistics that there are many fewer females in academia anyway. So that's one issue in terms of research. The other issue is the numbers. The third issue is the panels, the grant funding panels, for example. So you imagine that it's anonymized, but actually UKRI, for example, awards much smaller amounts of its funding to researchers of BAME background than you can account for by chance. And so you wonder, is there something about the grant writing? Is there something about the people reviewing them? Are they not anonymous? Can you tell who they are? There are all of these various issues. And so if the BAME researchers are not getting the funding, then those barriers that we're talking about that patients perceive are continuously being reciprocated. Now, if the research isn't being done on BAME people, then it's not actually reflective of the society as a whole. And then are those results necessarily extendable, and are they relevant to a BAME person who then comes in? There are studies again in America, for instance, in my field, child abuse, despite what you find, if you feel that if the child is then of an ethnic minority, they're much more likely to conclude abuse than if the child isn't. So there are numerous examples. We could go on, but yeah.
Yeah, so in my little sphere, you know, N of 1, I'd like to think of myself as being, you know, as they say, colorblind, because, you know, I don't think of it influencing. But I think, as Amaka said, that there is data, particularly coming from America. So for breast, I think for breast screening, for example, and outcome in breast imaging, that seems to be poorer for people of ethnic minority. And also there is poorer uptake of people in America of lung screening, for example, and also they're worse affected for various reasons. So these are the two things that I was aware of particularly. But as I said, you know, it's not just about gender and also about race. There is also, you know, I think one of our colleagues, Dan Saunders, he's a huge kind of, you know, ally and also a sponsor and you know, a real kind of fighter of the rights of people from the LGBT community. And he's worked relentlessly for the last 20 years in this field to try and improve. He's an oncologist, mind, but he is trying to improve kind of outreach to people from the LGBT community and making sure that they're treated, you know, as well as anybody else anybody else really in the UK, and also to make sure that there greater inclusion of these people in clinical trials. So you know, I think there is work to be done.
I think it's also worth mentioning that places are trying. So research ethics committees will now look at the inclusion and exclusion criteria and are very keen to understand why somebody's being excluded on the basis of age or other of these protected characteristics. The National Institute for Health and Research has got a program, the framework that they include framework for underrepresented groups, and they define them. So it could, and an underrepresented group may depend on the actual research question being asked and varies. So they have a framework that allows the researcher to ask themselves and to make sure that they're not being discriminatory against any particular underrepresented group. And when by the time you've worked through that, you'll be able to understand whether there is a good reason for excluding it. And I chair the Sheffield Children's Hospital Scientific Advisory Committee. So once a year we sit down and we look at grant applications to be potentially funded by the Children's Hospital charity. And you realize that people are not necessarily as educated as they should be. One project, they spoke about excluding people of BAME background because of lack of English. And I mean, I'm chairing the committee, I'm of BAME background, I do sincerely hope I can speak and read English. So they mean well sometimes, but we have to educate as well. And you'd be surprised at the level, at some lack of knowledge that some people do have. But there is the recognition, and there are changes being made. UKRI earlier this year launched, it might have been last year actually, they launched a funding package to try and increase the number of BAME academics remaining in academics, going into and then reaching the higher echelons of academia. And the more you see of people who are like you, be it LGBT+, be it disability, be it race or sex, then the more enthused you are. And a person of a particular, protected characteristic who then hears someone with that same characteristic is much more likely to be inspired. And the more we have of, it's one of these positive cycles, the more you have of diversity within a panel, then the more diverse the people you employ are going to be. And it just will become a positive thing. It's going to take time.
Do you feel that there is a Eurocentric bias to the curriculum in medical school teaching or radiology training?
I think that there is. I don't know necessarily how wrong it is. I mean, when I was training in Nigeria, I never saw a lung cancer. So a nodule on a chest radiograph in an adult was going to be TB until proven otherwise. And here it's less likely to be TB. You know, I'm talking about a middle-aged smoker, for example, depending on the context. The world is shrinking, so there is more travel and there's more diversity, and they're going to see some of these diseases more often in all the various countries. But I think there has to be a focus on what is endemic within an area, but then there does also need to be the teaching of what is more prevalent in a particular ethnic group, even within that area, if that makes sense. So diabetes, for example, being more common in Asians, and sickle cell occurring in blacks. So and some of the Mediterranean populations, there needs to be the context. I very much like the book that was published showing what jaundice or what purpura or what bruising might look like on darker skins. So those sorts of things I also think are helpful. So I guess I'm slightly I'm in favor, but I don't think that you have to completely, you do have to teach people what they're more likely to see.
I agree completely, and I think there is a kind of there is that UK kind of move. I think most of the medical schools are doing, isn't it? But this kind of decolonizing of the curriculum. So so I think there is efforts to try and inject more diversity into the curriculum, and making sure that our students are seeing the breadth as well as the depth of conditions, and also, you know, including different people of different sexual orientation or disability, and not necessarily portraying these in a kind of illness context as well. So there is that kind of balance to be built. But yeah, so I think, yeah, I mean, I agree that we should obviously teach our students the most common disease in that population, but also the kind of diversity concept.
Yeah, it's interesting that you do. I think it's a good point that you raised concerning that terminology of decolonizing the curriculum. And something that you can do in medicine is really promote the different people, LGBTs and BAME, who actually have contributed significantly to medicine as we know and understand it now, and not just concentrate on cis-sexual, middle-aged white men. Women have done things, transsexuals have done things, lesbians and homosexuals, BAME. So we need to just put all of that in the correct context. And where theories and principles have come from Africa or India, we should be able to put them there in a positive light, not the negative things and there is negativity in every culture. And so we should try and be more balanced in what we present.
Thanks so much for your replies. And I just want to ask, do you have any advice for medical students who wish to pursue a career in radiology?
Go ahead. I have no regrets from having done radiology. Depending on how soon you decide that you want to do radiology, if it's soon enough, I would suggest that they select it for one of their SSC components or for an elective. I think that they would do well to try and get a little research project. The Royal College of Radiology, I think once upon a time used to have its research map, which tells you where radiologists are who are academic, but even within a non-academic training, sort of department, you can, if there is no professor, which is unlikely, but you could do audits, you could do little service evaluations within radiology, get a paper or two, very friendly people, very supportive people, and also mentoring. So Cindy has talked about some of their mentoring schemes. And I would say websites, you've got to understand what you've got to do. You will have to apply through Oriel. It's a central website. You will expect yourself to be interviewed and to answer some tough questions. But it's a great specialty. I don't have any regrets at all. I'll let Cindy say something as well.
Oh yeah, I completely echo that. I mean, absolutely, the best thing ever. Radiology is the best thing ever. I mean, well, I suppose we're kind of preaching to the converted here. Radiology is such a good specialty. And yes, if you want to do radiology, come early, meet people in the department. We're all super friendly. I don't know what you hear in the wards, but we are really, really friendly. and, you know, SSC electives, as Amaka said, websites. I think one of the kind of really helpful one is the SRT, you know, the one that Lucy belongs to, and it shows you the process of how you can apply and how you know, what are the points that you need. So that's very helpful. The RCR has an annual undergraduate day as well, and they also have prizes that you could, you know, write an essay and win some prize. So these are the other two things you can kind of do to make your CV look good. And the RCR undergraduate day is going to be, I think it's going to be face-to-face this year, I think. So fingers crossed, maybe see you there.
What Akib didn't say in the beginning is I'm the honorary chair of the Sheffield BAME Medics Society. Anybody who wants to do radiology in Sheffield or on the Sheffield training scheme, I'm very open. I have an example, Samuel Crompton. He did a 6-week attachment with me. He got a paper out of it. He presented 1 or 2 presentations at an international conference, and he is now 2nd year, perhaps 3rd year radiology. So positive. Come.
I forgot to actually mention, also join your own medical radiology society in the medical school. So a lot of these ones have them now, so that's really good. And I also like to sort of kind of give a big shout out to one of my medical students. Her name is Jess Lee, and she is she did an SSC with me, and she's had 3 posters accepted, and you know, the ECR, all various academic kind of meetings, and we're in the process of writing that paper up. So definitely come and speak to people, and you know, there's always something to do.
That's right. Speak to them, make it clear that you would like a poster or a paper out of it, because then they will select a project that will allow that to happen.
Thank you very much, Professor Offiah and Dr. Chu, for your time in this Q&A. I'm just going to bring up a slide with the social media handles for the societies involved. The Glasgow Radiology Society, you can find them on Twitter at Glasgow Radio Soc. The University of Sheffield BAME Medics Society on Twitter at Shef BAME Medics, and on Instagram at Chef_BAME_medics. And the Sheffield Radiology Society on Instagram at Radio Soc Sheffield.